So this what is myocardial protection is the strategy used either to attenuate or prevent post-ischemic myocardial damage during cardiac surgery. So the factors that can affect the myocardial protection are usually it is done when you do a open heart surgery going with the patient into cardiopulmonary bypass, like valve repairs or other intracardiac procedures where you stop the heart completely, make it a standstill, and then do. That is the situation where this myocardium damage and get damaged. Whereas the CABG that is nowadays done during with the beating heart, that does not cause much of a problem like this. So we don't come across this problem of myocardial, the need for myocardial protection in such cases. But when you stop the heart completely by putting the patient on cardiopulmonary bypass machine, that is where this problem happens. So the pre-CPB hemodynamic stability is one of the important things. Then what is the cardioplegia technique that you are going to use? How far the repair of the surgical procedure is successful, and whether you are able to easily separate the patient after the completion of surgery from cardiopulmonary bypass, and what is the behavior of the heart after the separation and in the early period of post-op period, and whether any pre-existing system and cardiac diseases are likely to affect the performance of the heart. So these are the factors which you have to take into consideration. And intraoperative factors which can produce or cause myocardial ischemia are mainly our anesthetic technique. Cardiac open heart surgeries, there are two types of techniques. What are the anesthetic techniques that you commonly follow from the rear for cardiac surgery, open heart surgery? Any idea? Opioid based or inhalation technique based. Okay, that is how they classify the anesthetic technique. In opioid based, you give high dose of fentanyl. Normally, in our practice, we give only about 1 to 2 mics or maximum 3 mics per kg of fentanyl. Whereas here you start with 10 to 15 mics per kg and go up to 50 mics per kg also. That is called high dose opioid anesthesia for cardiac surgery. The other technique is inhalation technique. So inhalation technique is supposed to provide better protection because of the point that she mentioned last, that ischemic precondition that happens better with inhalation agents rather than with opioid agents. So the anesthetic technique has a saying, intraoperative, if you don't take care of the volume and if you don't preserve the LV function, if arrhythmias, especially tachyarrhythmias happen or hypertension happens, and if there is any ventilatory failure or direct cardiac manipulation by the surgeon and the surgical approach, especially the mid-cab or OP cab, all these things can cause myocardial ischemia. Now, what factors will help to preserve the myocardial function? You should have first a good ventilation, prevent ventricular dysfunction, prevent vasospasm, produce a stable hemodynamics throughout, avoid bleeding, maintain coronary blood flow. If all these things are taken care of, you can avoid them. And the basis of adequate myocardial preservation during cardiac surgery are, you must induce the cardiac arrest to make the heart become standstill in a rapid fashion. You can use hypothermia to reduce the oxygen demand by the myocardial cells, proper buffering of cardioplegic solution, and avoidance of substrate depletion, preventing intracellular arrhythmias. Now, which electrolyte is the most important one which is used to induce cardiac arrest? Potassium. All of you know that it is potassium. Okay, and what are the mechanisms of induced cardiac arrest? It can be extracellular concentration increases the resting membrane potential. That is from normal. What is the normal resting membrane potential?
Minus 90 millivolt.
Minus 70 to 80 or even 90. Okay, so it is very deeply negative. And if it reduces to 50, minus 50, it is tending to become more positive. Okay, even though still it is negative, it is becoming more positive. So the resting membrane potential is altered, which will inactivate the sodium channels, which will not allow the sodium to enter. Calcium channel is activated, resulting in cytosolic calcium overload. The optimum concentration of potassium which is needed for all these changes is about 15 to 40 millimoles per liter. So we have a high potassium containing solution which is used as a cardioplegia to arrest the heart in diastole. That is what is commonly done. And this is the things that will happen if you stop that. It will deplete the high energy phosphates, intracellular acidosis will happen, intracellular calcium level will get altered, free radical will be generated, and there will be edema chances. So this picture tells you the various things. Extracellularly you give high potassium, and that causes the alteration in the resting membrane potential, and it blocks the sodium channel, activates the calcium channel for more calcium to come inside. So when more calcium gets inside, and this exchanger also helps to close hydrogen ion and sodium ion exchanger. So all this result in depolarizing arrest of the heart, leading to standstill of the heart. Okay? This is another technique called polarized arrest, because this is not commonly done, and where sodium channel blockade and potassium channel openers like Myocardial are all used. These factors, some of the factors which can cause reperfusion injury after the myocardium has been made to become standstill and the surgery is done. And once the surgery is completed, you again allow the blood to flow. So myocardial blood flow is restored. At the time, you can have reperfusion injury because of calcium load in the myocyte, free radicals, neutrophil activation, and complement activation. These are the four factors which will cause reperfusion injury. So, clinical manifestations of reperfusion injury after the surgery is completed are dysrhythmias and systolic or diastolic dysfunction. Whereas histologically, it may produce myocardial necrosis, endothelial dysfunction, apoptosis, edema, etc. These are not visible easily, but if these things occur, you have to suspect that there is a reperfusion injury happening. How to minimize these things? Decrease extracellular calcium, use antioxidants, control the reperfusion. Mannitol may be given to scavenge the free radicals. One of the uses of mannitol other than being a diuretic. And the types of cardioplegia that are used is all asked in the exam, and it can be blood cardioplegia or crystalloid cardioplegia. The merits and demerits are blood cardioplegia, it has the oxygen carrying capacity. That is the major advantage, and it has a buffering ability. It can also scavenge the free radicals, can maintain osmolality and electrolyte balance, but it is expensive, and the application of that is more complex. Whereas crystalloid, it is inexpensive, readily available, simple to use, but it doesn't have any oxygen carrying capacity, no buffering capacity, and when you use it, it may dilute the blood and produce hemodilution. And the difference between myocardial stunning and hibernation, which may be sometimes asked in the examination. So they are nothing but part of the same clinical spectrum. In both of them, there is a lack of blood supply, but stunning, the resting coronary blood flow is usually preserved, whereas in hibernation it is decreasing, and stunning is an acute thing, it's a short spell, whereas hibernation is a chronically dysfunctional myocardium, and these are the changes that you will see. In the stunned myocardium, there is an acute ischemia, and perfusion gets decreased, function also gets decreased, and once the reperfusion occurs, there is a relief. Post ischemia, there is a restored perfusion, decreased function, but viability is maintained. Whereas in hibernation, it's a chronic condition, and there also perfusion is decreased, function is decreased, but preserved viability is preserved in both of them. That is the reason why both stunned myocardium and hypernating myocardium can get back to normal function once if blood supply is restored within the reasonable time. And the stunned myocardium will come back to faster activity and normalcy more than the hibernating myocardium. That is the difference that we have to remember. And what are the various percentages of stenosis of coronary vessels and what are the effects of that? So if you have 40% stenosis as reported after an angiogram, then it does not affect the maximum coronary flow. That is, resting blood flow is also normal, and when the patient is exercising and needs more blood supply, the maximum coronary blood flow also will be preserved. On the contrary, when the stenosis is between 40 to 80% reduction, maximum flow will reduce, but resting flow is still unaffected. But beyond 80%, there will be a gross reduction in both resting blood flow and maximum blood flow required during exercise. Okay, so these are the three important things. So 40%, that is why when you go to a cardiologist and when they do an angio, 40%, they will say nothing to worry. You can just go for a walk and improve your collaterals. Whereas if it is 40 to 80%, your maximum flow will reduce. That is, you will start getting anginal pain because when you briskly walk, you will not get adequate blood flow. But your resting angina pain will not happen because resting flow is still maintained. But once the block becomes more than 80%, both resting angina pain will come as well as during exercise because both will be grossly reduced. So this is the importance of the various degrees of occlusion that is happening. And so these are the points that we have to write in case of myocardial protection. Okay?